Thank you all, attendees, for being here at this Living Health Author Q&A series sponsored by the Center for the Study of Human Health at Emory University and co-sponsored by the Georgia Center for the Book. I'm your host. I'm Maryn McKenna. I am a journalist and author and senior fellow in the Center for the Study of Human Health. And my guest tonight is the author of the fantastic book, The Kissing Bug, Daisy Hernández, who is an associate professor at Miami University in Ohio and a journalist with credits including The Atlantic and National Geographic and other incredibly distinguished outlets. Daisy, thanks for coming to talk to people about this wonderful book.
Thank you so much for having me and inviting me. I really appreciate it.
I was saying to Daisy before we connected with the rest of you that Chagas disease, which is the subject of this book and what we're going to talk about tonight, has been a minor obsession of mine for quite a while. People who know me know that I am sort of scary diseases girl, and I am particularly interested in neglected tropical diseases, such a rich phrase for such a terrible, terrible affliction for so many millions of people around the world. And so I was uniquely delighted when I heard about your book coming out, because it was something that I wanted to know so much more about. So thank you for writing this and for bringing attention to this underappreciated, in many parts of the country, unknown and terrible disease.
Yeah, thank you so much. And I'm so happy to hear that someone else has minor obsessions with these diseases, because yeah, they are so neglected. That is such a choice phrase, terminology.
Before we get started, I want to remind all of you who are listening that this is a Zoom webinar, as opposed to the regular Zoom meetings that probably occupy your days and mine. And so what's different about a webinar is that you cannot appear on camera. You communicate with us through the Q&A box at the bottom of your screen, and you can also talk to us if you want to, separate from the Q&A box, through the chat function, which I will see. If you have questions for us as we are talking, at any time, please pop them in the Q&A box. You do not have to wait until I announce that it is time for you to ask us questions. At any point in this conversation, if anything occurs to you, pop it in the Q&A box at the time. It won't go away. I will see it, and we will see it when it's time, about halfway through this hour, for us to start considering audience questions. But the benefit of being moderator is that I get to ask the questions first. So, Daisy, this book is just extraordinary. It's a family history. It's a detective story. It's a memoir, and it's kind of a polemic as well, establishing the stakes of this disease, as we were just saying, that is so profoundly important in so many countries of the world, including this one, and yet has unaccountably never really received much public notice. So where I'd really like to start is, can you tell us the story of how you came to tell the story of this disease and its intertwining with your family history? What started you on this?
Yeah, I started, as I write in the book, I started talking about Chagas disease when I was very young, because my auntie was diagnosed when I was about 5 years old. And so I was sometimes interpreting between her and medical care professionals. Mm-hmm. But of course, when you're 5 and 6, you don't appreciate exactly what you're saying, even though you're using the words and, helping someone navigate language. But I essentially grew up in the shadow of this disease, and we thought it was very rare. We never met anyone other than my auntie who had this diagnosis. And many, many years later, when she died, it was quite a shock for me. And so I actually first began to write fiction about it. I was trying to write a short story about a little girl who loses her mom to this disease. Mm. And that's where I began to do some research, And so as I tell people, be careful, because you might start doing a little research and end up spending the next 7 years of your life working on a book you weren't exactly planning to write. But for me, I think what happened was that as I started to learn more, the shock really started to hit me, realizing that my auntie had not been the only person in the United States with this very deadly disease. There's 300,000 people in the US with Chagas disease. And they're all like her. They're immigrants from South America, Central America, and Mexico. And I really began to wonder who they were, what experiences they'd had, if it was similar to my auntie, because This parasite predominantly goes after the heart, can lead to really serious cardiac complications for about 1 in 3 people who are infected. And for people like my auntie, the parasite can attack the gastrointestinal system. And there isn't a cure once it's in that chronic form. So my auntie, she had some years that were really good. She had a very full life in many ways. And then she had years where we spent weeks, sometimes months, with my auntie hospitalized. She had abdominal surgeries. A lot of medical interventions before she finally lost her life to this disease. And so I really wondered, what were other families going through? Just as a journalist, I know that there are so many stories from Latinx immigrant communities that we never hear about. I realized that this was one of them. I was so surprised that there wasn't already this book. For general readership, there's definitely wonderful academic texts about the disease. But I wanted something that, my best friend would read, would pick up at a bookstore or in a library. And also I became a book because I did meet those families. And I started learning so much more about the disease that I didn't know, including that very similar to the Zika virus, this parasite, Trypanosoma cruzi, can pass from mother to child during pregnancy. I had no idea about that before I started working on this book, meeting people who got to the point where they needed a heart transplant. So I realized that it was more than just one magazine story. And then, of course, as I started researching, it has even a complicated history around its discovery in Brazil in 1909. I ended up finding just so much information about this disease in the US that was really disturbing, including a racist medical experiment. So as I did more and more research and more interviews, it just kept growing. And I realized pretty early on, this had to be some kind of book. Yes. Yeah, exactly.
I recognize that feeling when suddenly you realize the thing that you thought would take 5,000 words, 10,000 words needs 10 times that much. Mm-hmm. Oops. Mm-hmm. So we should say here, for people who haven't read the book, that your interest in this starts because you are from an immigrant family. Your mother's family are Colombian, your father's family are Cuban. You were born in the United States. And the auntie whom you're speaking of was your mother's sister. And she was ill from before you were born in Colombia.
Right. She started experiencing symptoms when I was around 3 years old. Mm-hmm. And she had some medical care there in Colombia, but there wasn't a diagnosis of Chagas disease until she got to New York City. Her story is very unusual. I was actually resistant to having a memoir part to this book because her story is so deeply unusual. Someone recently asked me, how many immigrants come to the US to get treatment or care for Chagas? And as I was explaining to that person, there isn't treatment in the sense that there's not a cure. There's treatment that will reduce the parasite load, but most people that are in the United States with this disease do not realize that they're infected, actually, because the majority of people their systems will live with this parasite without actually developing any medical complications. But most people have never even heard of the disease. It's been neglected not only in the US, but across the Americas and across Latin America.
But your mother's family had the sense that it sounds like they knew what was wrong with your aunt, or at least they knew that there was a parasite involved, or there was an insect exposure involved. There was some sort of folk wisdom around what was going on.
The women in my family are a very determined, resilient lot, that little tribe of very resilient women. What they knew, they actually didn't know about the insect or the disease at that point, but they had, my mother and another sister had been in the US for a few years, and they were very convinced, and rightly so, around 1980, that everything in the US would be better. So they put money together and they brought my auntie here in the hopes that there would be some kind of medical care that could save her life. Because at that point, the prognosis from her doctors in Colombia was that she had about 1 to 2 years to live. Mm-hmm. And they had actually lost a sister who was, when she was just a toddler, to probably some kind of parasitic disease. I don't know. I don't think it was necessarily Chagas, but they very much grew up with these stories of very suddenly losing a sibling, and their mother having lost a child to some kind of disease. And so I think that might have made them more determined. They never spoke about it that way, but they were very conscious that they had lost a sibling. And so they really threw themselves into the idea that they could save their sister. And they did. They absolutely did in a lot of ways. Yeah.
Let's follow your aunt's history a little bit more before we talk more about your history in sort of uncovering the intersections of your family in this disease. She came to New York. She and your family found medical care for her. They went into Manhattan. They found a hospital that did what we would now consider indigent care. She got surgeries, and she lived for a number of years, right?
She lived for about another 3 decades. So she got a complete, lease on life, like a new lease on life. Yeah, absolutely. And it's basically the stars lined up for her. She was connected with Dr. Alfred Markowitz at Columbia, what was then Columbia Presbyterian Medical Center. And he's actually been celebrated in the pages of the New York Times as this like old school physician who knew about, was very passionate about, medical history, and like tended to really not only know very obscure, what were considered obscure diseases, but he would also quiz his students on the spot and his residents on the spot. Like he felt they should have a really wide knowledge of disease. I suspect that that's the reason that he may have even suspected Chagas, but it was very, very unusual for a doctor, especially in 1980, to know about Chagas disease. It's still, it's becoming a bit more known now, but when I started working on this book 7 years ago, it was still very unusual to see a doctor who knows about the disease. It's still unusual, but more doctors are becoming aware of it. So she was very fortunate.
Trace for us the point at which you started to understand what was going on with her, not just that she was ill when you were a child, but that she was part of this larger story that stretches through the Americas.
Yeah, I learned there was like a little bit more that I was learning as I was like in my 20s. I learned a little bit more, but it was really in the wake of her passing when I started to read more. I was never someone who read medical journal articles or science articles. My background is in English. I teach in the English department. I always have to say that. So for me, it was actually, in some ways, I think that I took this on probably to negotiate with my grief, because my auntie and I had a very complicated relationship. She was like a mother to me. So sometimes people say, "Oh, she was your auntie," and they look at me a little quizzically. And it's like, no, she was a mother figure to me, and I saw her every single day. We were very close as a family in that sense. And but we had such a complicated relationship because I came out as queer when I was 25, and she never was able to accept that. And she really struggled with her homophobia. And so she stopped talking to me for a number of years, and we reconciled actually about a year or two before she died. But I didn't feel entitled to grieve, the loss, because we had such a complicated relationship. And so throwing myself into science articles and throwing myself into reading about this disease was actually, in some ways, really helped me to negotiate with that grief itself. But as I said before, like as I kept finding like that it was so much larger, 300,000 people in the US. How have we never heard about this, And of course, 6 million across both Americas. So it's a lot of people for us to not know about what they're going through.
So I really think we should talk about that. Late in the book, you talk very movingly about the formulation from Paul Farmer of Harvard and Partners in Health, very, very famous public health sort of secular saint. His formulation of the epidemiologic divide, and that this divides the rich countries and poor countries, people who are privileged from people who are not. And the way you frame it or reframe it is that when we talk about the divide, or when we talk about disparities, which is a phrase, disparities in health is a phrase that we toss around a lot. It almost sounds like a kind of natural phenomenon, that you happen to end up on one side of the mountain or the other, or one side of the valley or the other, and you just are there. But in fact, this is a choice that we make. And the way you reframe the epi divide is as people whom we choose to take care of and not take care of, or to not create policies that will allow them to be taken care of. Can you talk a
Absolutely.
bit about your sort of dawning realization that of how Chagas intersects with this, of how important this denial of care is?
Yeah, it was such an important moment for me when I came across that particular phrase. And I like how you said Dr. Farmer, secular saint. And yes, I was reading, all of his articles and reading Tracy Kidder's book, Mountains Beyond Mountains, about him as well. And when I came across that, I thought, yes, that is it. Because just as you were saying, disparities in healthcare, even the phrase racial disparities, it sounds like we haven't done anything. We're not culpable. It somehow just appeared out of thin air, but we have made choices. And I think Dr. Farmer's work, makes that very clear. Like we've made choices about where we establish health clinics. We make choices about who gets the vaccine right now. And so for me, when I was reading his work across these 7 years that I was working on this book, and as I was thinking about, other diseases as well, it began to come together because I was part of that first generation that learned about HIV and AIDS in school as part of our science class in 6th grade. But we were introduced to this, and this was still really early in what scientists knew about the disease. And I realized, as I write about in the book, that many of us in the U.S. think about HIV and AIDS as something that has been dealt with, but it is very much an epidemic in the Black community in the United States, in the South, among men, and we don't talk about it in those terms outside of people who are in public health. Ordinary, regular folks do not talk about it that way, and I began to realize, yes, we make such an active decision about where these lines are. And I really feel that we have a policy that when it comes to these diseases, we have a policy of containment rather than eradication, that we reach a point in which we say, this is good enough. And why is it good enough? Because it's not affecting middle-class white America. We can keep it contained to a particular part of the Black community. Or with tuberculosis, another one. Like, I know for myself, I did not grow up thinking about tuberculosis at all, but in many immigrant communities, they are thinking about tuberculosis because we did not eradicate that around the world. For folks who have been in homeless shelters or in the prison system, have also been much more vulnerable to TB, right? It just seemed to me like this analogy of this epi-divide, this we've put this line down. And something that was important for me to write about in the book is to acknowledge, for those of us who have access to health insurance, for those of us who do not have to worry about Chagas disease because we're not worried about coming into contact with the insect, right? That's going to be your primary way of transmission. And so we just think okay, I'm safe over here, right? That's part of what's so, just so incredible about this idea of the epi-divide is that it offers this kind of fantasy of safety, like I'm safe over here. But then as I write in the book, there's an epi-elite, this epidemiological elite, right? People who can pay $80,000 a year to have a doctor on call, a boutique medical service, and so realizing it's just an illusion of safety. You realize oh, I'm actually not in the epi-elite. Where am I actually standing in this divide? So I feel like I feel like it's really important for us to think about just the hierarchy that we have when it comes to healthcare. Maybe sometimes even hierarchy is a better word than disparities, I think.
So I've been thinking a lot about the HIV epidemic lately because, of course, this past summer was the 40th anniversary of the first identification of the first cases of HIV recognized in Los Angeles, published in a very famous bulletin by the CDC in June 1981, happens to be right next door to Emory. Probably people who were involved in that first bulletin probably teach at Emory now. And yet my students at Emory have only ever known HIV as a chronic disease, unless they happen to come from a country where HIV, as you say, if they're from sub-Saharan Africa, where HIV is still a much more present threat. And we saw that same, I guess, lack of historical consciousness or lack of consciousness of the vulnerability of the marginalized in the COVID pandemic, when the infection and death rates, particularly in the early days in New York City, were so astonishingly higher in Black and Latinx communities, not because of their race, but because of their socioeconomic status and the fact that they traveled to work that they couldn't give up on packed public transit, or they lived in multi-generational housing. It really brought home for me how this epi divide is still so vivid for us if we only look.
Absolutely. And I really want to underscore something that I saw happen with COVID in those early weeks was that it was scholars and journalists who pushed back on this narrative, because there was actually initially a narrative of like, oh, we have to figure out what's happening with these particular, racial groups. And it was amazing to see scholars and journalists stand up and say, there's actually, there's nothing innately wrong with the Latinx and Black communities in this city, but they really had to, like, it was incredible to see people, both in articles and op-eds and obviously on social media, really push back against, there was an emerging narrative that was going to basically blame Black people for having COVID. Mm-hmm. And it was amazing to see that pushback happen. And I don't know that like 20 years ago, how possible that would have been without social media, specifically without social media, and also without like certain kinds of access available. Specifically, I'm thinking like for Black scholars and academics. Yeah.
So I just want to remind the folks who are listening that the Q&A box is open to you at any time. If anything that we are saying prompts a question, please pop it in there. I see we already do have one question in there, and we are going to get to those before too much longer. I think, though, we haven't really talked about how Chagas disease is transmitted. And I think now would be a good time, because that really also slots into this narrative of who is privileged and who is not. So tell us the gruesome details.
So yes, part of the reason that the book is called The Kissing Bug is because the primary mode of transmission is going to be from contact with these triotomine insects. There's more than 100 species. There's about 5 of them that in Latin America are considered to be the most dangerous in terms of their ability and the most likelihood, right, of transmitting this parasite. What's a little different about transmission with Chagas disease is that usually, we hear that there's a bug, a vector involved, and we think, okay, bug bite, and that's how it happens. But in this case, it's not. There is a bite from the insect, but the parasite's actually in the fecal material. So the parasite is biting you, it is defecating, and it's in that material, which then enters the bloodstream either through contact from rubbing it into the bites, or from the material getting into the nose, mouth, the eyes. And the symptoms are not very alarming in that acute phase of the first about 8 weeks. There could be fatigue, there could be fevers. In general, though, they're either mild or could, you would easily attribute it to something else. You wouldn't be alarmed. One symptom that became a marker for diagnosing it is that you'll have one eye that becomes very enlarged. It looks like you have a marble under your eyelid, and it can be discoloration. But again, you have to know a couple of things to be able to even diagnose it with that particular symptom. Like, you have to know that the patient has contact with these insects. You have to know about the disease, and you have to know so many things in order to be able to identify it. But, in a lot of cases, in Latin America, specifically, I'm thinking in South America, Central America, and Mexico, because you don't find this in the Caribbean, these insects. It's sort of a known fact, like if you have people living in contact with these triotomine insects and someone wakes up with that kind of swelling, they most likely have been infected. The parasite is now in the bloodstream. The parasite is, I think I said to an expert once, it's very cunning. And he's like, no, the parasite's very clever, very smart, strategic parasite. I would still probably say cunning, but the parasite has figured out, to evade the immune system. It is ending up, like I said before, it does target the heart. There's been a lot of research into where it seems to hide out in the body, that it manages to evade that immune system, but it does target the heart, and it can do all sorts of damage with the electrical system of the heart, with the muscle itself. So you have patients who end up with aneurysms, with very irregular heartbeats. However, the parasite can live very dormant in the body. Those symptoms do not start immediately after that acute phase. So there's a very dormant chronic stage, right, where this parasite can be in your body for as many as 3 decades, so 30 years. And one of the things that I would underscore is that in Latin America, and this was true in my family as well, because of that lag time, it means that someone is often can be infected as a child and doesn't have symptoms until they're very much an adult. And so there's a perception that this is an old person's disease. Mm-hmm. And in fact, one of the patients that I met, that's, whose child was born with this parasite, she very much was so confused because she had never heard of a baby with Chagas disease. She didn't know about congenital Chagas disease. And so there's such a perception that this is something that only happens to adults. So I think that's important to keep in mind in terms of like public knowledge of a disease and how communities perceive a disease. But yeah, so, and once it's in that chronic stage for adults, like I said, there isn't a cure. You have 2 drugs that were created back in the 1970s. That's what's still available to us because this is a neglected disease. So money has not been thrown at it in that way. But something that's important to remember with transmission too is that for some reason, children and even teenagers respond really well to the medications. And so that's important because, there's an Argentinian doctor who said, we really need to think about this not only as a zoonotic disease, but really as a pediatric illness, right? And to be thinking about, if we catch it with children, we actually can stop this disease progression. But unfortunately, it's still an uphill battle in terms of just diagnosing patients and getting them treatment in Latin America, as well as the United States, but for children in Latin America.
So a thing that I don't think we should let get away before we move on to so many other pieces of this story is that one of the reasons for people's vulnerability to this is what we would think of as substandard housing. There's a moment in the book where one of the experts you talk to in Latin America says, if we rebuilt people's houses, if we changed the way people are housed, then this bug would not be dropping out of palm frond ceilings in their mud brick houses onto their faces as they sleep. So it's not just that it happens to be they're not just geographically vulnerable, they're vulnerable because of their poverty.
Absolutely. These insects, like as you're describing, it's rural housing where people have made their homes like with mud and bricks and very natural materials, which makes it really easy for these insects to hide in. But that's what they also have access to in terms of building their housing. There hasn't been huge investments in infrastructure. And what's interesting in the US is there was a case in Louisiana where a woman ended up, if I remember correctly, it was like about 40 kissing bugs in her home. She ended up infected as well, right? Because it was the level of exposure that she had to these insects. So, it also can happen here, but it's the reality is that we have better infrastructure, even in our very poor communities, but we could also be easily vulnerable if we made a different set of decisions, right?
I want to put a pin in that and come back to the question of Chagas in the mainland United States, but about current vulnerability. But where I want to go first, because you tell this astonishing story in the middle of the book about research into Chagas here in the US, an absolutely chilling story from the 1940s of how a physician in the US Public Health Service researched the transmission of Chagas. Can you tell us that?
Yeah, he was actually sent to Texas to see if transmission was happening, because it was very known that Texas and other places in the South had the triatomine insect. he was not finding cases themselves. And so apparently at some point he approached the Austin State Hospital, which was a hospital for people with mental illness. And by 1940, many people were there for what we would now know to be bipolar, or also schizophrenia, were like the common diagnosis translated into today. He collaborated with doctors at the hospital to experiment on patients, and published his findings. So we know, I did archival research and found letters that were exchanged with the doctor that suggest that it was actually not just one patient. There had been more. It was sort of a plural of the patients. But he published his findings based on one experiment on a young Black man, where the researcher basically took insects that are native to Texas, that he knew were infected, crushed them, introduced that parasitic material directly into the young man's left eye, and then basically sat back and followed the disease progression at that time. And of course, the young man was infected. He actually developed what I was saying, that swelling, which is called Romania's the Romania sign. He developed that. He developed fever, swollen lymph nodes. He was in distress, and he was basically used just as the researcher was also experimenting on mice and rabbit, other animals as well at the same time. And he basically used this young Black patient in the same way. And of course it's so horrible in so many ways, and including the fact that the work was published, accepted into a journal. It still stands online without any acknowledgement that this is a racist medical experiment. And he was very recognized, and was the researcher, and was even in communication, in a lot of direct communication with Chagas experts from Brazil and Argentina, who were at the forefront of uncovering Chagas disease. But yeah, it was quite a shock for me as I was putting together all the pieces of what he did.
So we should point out that this was at the same time that the U.S. Public Health Service was conducting the Tuskegee syphilis study, not that far away from Austin, Texas. And in the infamous Tuskegee syphilis study, men who had naturally acquired syphilis were denied treatment and the progression of their disease observed. This seems to me even more chilling, because this person, as with the later experiments in Guatemala, though that was for sexually transmitted diseases, this person was deliberately infected to the point where the researcher actually used that person as a lab animal and introduced kissing bugs to him and used him to reinfect the kissing bugs, which is incredibly chilling to me.
Yeah, that's the important part of the story too, is that at that point, we don't have antibody tests, right? And so the way that you would know that someone was infected was that you would then have, lab raised kissing bugs feed on the person. So like, not only was it introduced into his body, purposefully infected, but then the way to confirm that he was infected was by also having kissing bugs feed on his arm, to then be able, and then of course dissect the insects to confirm that the parasite was in them. But yeah, it was just horrific in so many ways.
And this person is lost. He's lost a follow-up. He's lost a history. We don't know his name. Unlike with the Tuskegee syphilis study, there were never congressional hearings. People didn't lose their jobs. It just stands as one more example of the if not the hidden and unacknowledged racism, unfortunately, in so much U.S. medical research.
Yeah.
So what I'd like to turn to is the sort of present threat of Chagas in the United States, because you said you met this woman in Louisiana who had been infected here. And over the course of the last part of the book, you do track down various victims of Chagas, some who knew their status, some who didn't, some who were part of a sort of multi-generational chain of infection. Talk about that detective hunt.
Yeah, so the CDC does keep track of people that it believes have been infected by in the United States by insects here. At last count, there were still fewer than 100 people on that list. We have the insects here in the US. Going back to what you were saying about infrastructure, we generally have better infrastructure in the US, so there isn't that level of exposure to the insects. There was a really interesting study. There's been more than one, but there have been interesting studies looking at the way these insects that are native to the US operate maybe a little differently from those in South America. So the way that the insect, how quickly it defecates may play a role, but these are like very, small studies that have been done. It's not a huge threat in the United States. Like I never found evidence that, we should all be panicked. However, what I do tell people is look at what the military is doing. So why is the military thinking about Chagas disease? They're thinking about it because the Defense Department has their large veterinary hospital in South Texas, right? And so their dogs, because dogs can pick up these bugs, can pick up the parasites. So we have canine Chagas. And so they have had military dogs, infected military dogs who have died from canine Chagas disease. And so what they have done based on the interviews that I did, and they've been open about this, is, they've cut back the brush around these kennels. They use more pesticides when they send their trainees, because also soldiers are being trained in this landscape in Texas. They send them out with mosquito net, with spray, right? Like they sort of do everything to protect, to protect their soldiers and to protect their dogs. So I say the same thing to others, if you're like my sweetie and you just want to be able to go into the woods, go out camping, you might want to think about that twice, and you get your bug spray on and have your mosquito netting and anything, just kind of give you a level of protection. Texas A&M in College Station, they have a wonderful, you can literally Google, I don't have the URL right on me, but if you Google for Texas A&M and kissing bug, they have a wonderful manual that they've put together in terms of thinking about your housing, specifically in the South and the Southwest. And also this insect is all over California, from north to south. What stood out to me is how incredibly arbitrary infection is in the US. And, to give you an example, there was a woman in Northern California who went camping with her husband and their 2 kids, and she got infected by a kissing bug. No one else in her, family did, even though, same campsite, same nights and everything like that. A woman that I interviewed in Texas, she believed she got infected at her mother's house. Her mother was fine, not infected herself. So there's sort of like a little bit of an arbitrary nature to this, because these were 2 cases where it wasn't high exposure to the number of insects. It was probably once or twice, and yet you just don't know. I sometimes tell people, you want to think about it similar to Lyme disease in some ways, right? The more ticks are on you, the higher the chances, right? But sometimes just even one tick, can do it.
So now's the time when I'm going to turn to our audience questions. I should ask you one other question, though, based on what you were saying about where the range of exposure is. And that is, do you feel that climate change factors at all into the risk now, or risk as it's going to be in the future? Is the range of the bug increasing?
Yeah, right now, I mean, a lot of it is projection, projecting what might happen when, but it's going to play a role, because these insects are very picky about temperature. They like it, warm, but not hot, not tropical Caribbean, right? But definitely not cold. So I always say like, oh, North Carolina in like the springtime, sort of like a balmy, a nice, 64, 74 degrees. But so we are seeing the insect has been identified further north in the United States than it ever has before. It's been identified in more than 20 states, just not in huge numbers, right? So you're going to see a lot more in Texas compared to, Ohio, for example. But yeah, you have to, and also on the flip side, though, is that what that will do is that some places will get too hot for the insect as well. We presume, that will also happen. Something else that I write about in the book is that not only climate change, but the land development, where we develop, because Texas is exploding in terms of housing developments, in terms of, private business going in and, putting up office buildings everywhere. And people forget, well, from the kissing bug's perspective, this is their place, and you're building a lot of housing in territory that these insects have been for, hundreds and thousands of years. And so one person that I interviewed, he's like, oh yeah, he's a veterinarian. So he knows about the disease that way. And his wife went to get her iPhone out of her pocketbook or whatever, and there was a kissing bug inside her pocketbook, and he kept saying, we live in a nice house with really good windows, everything that would keep a bug out. But, you're basically, treading into natural landscape, right, that hasn't been developed before.
So resonant of the maps I've seen for the advance of mosquito-borne diseases or the advance of tick-borne diseases. You mentioned Lyme, but also the tick-borne diseases that are more prevalent here in the South, that the diseases that we have considered that we have contained by pushing them into places that are less resourced or not dealing with them when they are in places that are less resourced, they're going to move out of those less resourced nations and into the first world nations as that climate range changes. And I don't think people have thought that through. So let me ask you some more about containment. Someone from the audience asks, when we were talking about the Epi Divide and about this decision of containment rather than eradication, have we seen that sense of hierarchy of what's worth working on and not, or who's worth saving and not in the COVID response?
Oh, absolutely. I mean, really early on, right? We saw that, who could get tested for the coronavirus, right? I don't know if you remember this, but early on, it was journalists who were out there telling us, hey, the testing sites are in predominantly white neighborhoods in New York City, even though the other headline was that the people that were being infected and were dying were in Black and Latinx communities. And it was journalists who were telling us, hey, as New York City and also even over in Texas, you were finding these testing sites to be in predominantly white and wealthier neighborhoods. With the vaccine, really early on, you saw decisions were being made, right, about where the vaccine was being offered. I struggled for several weeks, like many people, to get my elderly Latinx parents in South Florida vaccinated. And as happened in many neighborhoods, the vaccine was available at their local Walmart, and you had to have access to a computer. You had to have access to be able to make those appointments, to speak English. So if you were like my parents, who only speak Spanish, do not have a smartphone, would not know where to begin to make an appointment, you lose out. It was all over the country, where you were seeing people from outside of the community showing up at a community where some part of the policy had been, let's send this vaccine to this vulnerable community, but then other steps weren't taken to ensure that it was actually local residents who had access to it. And then, I think you've seen an incredible, shift, starting, with the Biden administration, of saying, like, we're gonna, specifically go out there and get the word out to Latinx communities, to Black communities, that it's good to be vaccinated, and we're going to use local health providers. And I think you've seen that shift also among healthcare providers, seeing Latinx doctors and nurses and others who work in the healthcare profession speaking in Spanish directly to immigrant communities. Same with Black African-American doctors. They're doing that, right? Going on local news stations saying, I'm getting vaccinated, to build confidence in the community. All of those are decisions that we've made. People have organized. I think what's so challenging about, policy and organizing is that unless you're involved in it, you don't see it. You're not on those like conference calls. You're not like seeing how it's all getting organized behind the scenes. You're just seeing the like news bite on the 6 o'clock news or somewhere on your social media feed or something. But a lot of work goes in there. So yeah, absolutely. With the Epi Divide, we've made huge decisions. I was vaccinated before my elderly uncle in South America. Someone made a decision around that, right? We made a decision about getting people in the US vaccinated, not necessarily elderly people globally.
I was vaccinated here in Atlanta before my elderly uncle in New York City, which is an expression of neighborhood access. Yeah. So I'm so glad that you spoke about the street teams and the community outreach and the individual work that Black and Latinx physicians and healthcare workers are doing around this, because the story that you just told us of a disenfranchised young Black man in the 1940s being used as essentially a petri dish for this disease is a perfect expression of why distrust in the medical system on the part of Black and Latinx communities is so justified. This is not something that they made up. This is lived experience to them or to their families or to previous generations, and those stories have been passed down. And so it really, I think, has called us to try to be creative and innovative in how we get out messaging around COVID, precisely because those communities are harder to reach because of things that mainstream America did. So.
Yeah, absolutely. With that young man in Austin, I have to believe, as you're saying, word got out somehow. I can't imagine, even if for some reason his family didn't have access to seeing him and knowing that he was sick, the other patients did, the attendants, that it was a very deep sense of hierarchy at this institution at that time. So the attendants that were working there would have known and would have seen what was happening. So I have to believe, as you're saying, it's like word gets out. And so there is like another medical history that is there, that is like very much, not always visible to us, but that is also so strong, and being carried from family to family over years.
Mm-hmm. Another member of the audience asks, since we're speaking about race, that we know that race is a social construct and has no genetic basis, but given that we're talking about these vulnerabilities to different populations, is there any way in which race has to be considered in medicine, even if it doesn't have a genetic basis, or would we be better off if we just kind of abandoned this concept entirely?
Oh, that's a great question. So I would say that actually, yeah, race as a social construct has to be always considered in medicine. So that's exactly how the question is framed is how I would say it, right? So, we have to think just with the COVID response, right? We can't just say we're going to be colorblind or not consider race at all, but race as a social construct and this history of medical racism means that when we go do a public health campaign, we need to think about the implications for this community, right? Like we need to be thinking about the historical context, the contemporary context as well. So thinking about race as a social construct, we have to consider. I have not been to medical school and all of that. So from the medical school perspective, I don't know. I would not begin to address that itself. But yeah, absolutely. In terms of like public health, race as a social construct is something that has to be considered. Yeah.
So I was happy to hear you mention your parents, that your parents are in South Florida. They're still living. How did they feel about the book?
Oh, they see, so my parents don't speak English. They don't read books in English. They don't actually read books in Spanish either. So they see it as something wonderful that I do out there.
That's lovely.
It's very separate from them. I always say, if I end up on like the local Spanish language news station, then they would be like, "What did you do? What exactly did you do?" But they were very involved in this project in the sense that I was constantly sharing with them what I was finding about the disease, because my parents and my other aunties didn't know about congenital Chagas disease. They certainly didn't know about canine Chagas disease, right? So as I was learning more and more and telling them, they were really amazed, and sometimes they were worried because I think I told them actually after the fact that, I went with some researchers from Texas A&M to go see if we could find kissing bugs around town. And we did find them. And so I think for my family, it was like a little bit of, wait, why are you getting that close, that up and personal with the insects? There were sort of some questions around that, but generally they were really amazed at what what I was learning in those years.
So I always want to ask a writing question, even though we're usually talking about the health and public health aspects of these books. And one of the things that I love about your book is the literal tone of it, the writing style. And it seems to me that it's not sort of straight didactic. It's not a strict chronology. In some ways, it's kind of impressionistic. And to me, it very much evoked the sort of Latin American magical realism tradition. And I wondered if you could talk about how your identity as a writer who is Latinx, who has an immigrant family past, did that feature in the style that you chose, or the voice that you found when you were writing it?
Oh, I think so. I think so, because I think growing up as the child of immigrants, navigating between Spanish and English, I was the person who was oftentimes speaking on behalf of my whole family as the oldest and the first one to learn English. All of that gave me a sense of, or gave me an ability, I think, to hold multiple realities at the same time, in the sense of like, oh, this is how you say this in English, and this is how you say this in Spanish. I remember my mother, when she first heard the phrase, oh, it's raining cats and dogs, and she was like, it's raining what? That was like so appalling to her. So, I was able to hold multiple realities. And I think then when it comes to my writing, a lot of times I am working with multiple threads, and I'm not very attracted to the straightforward chronology or retelling of events. I don't necessarily think in a linear way. I more think in a thematic way. So for me, the book is organized around like searching for my family story, searching for the insect and the parasite and the science and medicine, and of course, searching for the stories of other families. And so to me, like, that actually reflects so much. Being a Latinx writer is sort of like holding these multiple threads at one time, and finding when you're navigating different cultures, you have to be able to figure out what's the connective tissue, right? Like, how are these threads holding together? So I think that definitely influences how I write. And I really thought about the memoir as being the spine of the book. It was the bones, like everything was resting on that. So for me, it was really important that the voice be consistent, whether I was talking to a biologist or to a family or talking about my own story. So for me, like, thinking about it as the spine of the book was so helpful. Like, this is the center, the central road that I'm on, in some ways.
I really like that metaphor, sort of the skeleton that underlies the rest. So what I'd like to do now is just sort of, this is our final question, but it's not so much a question, it's a chance for you to kind of think of the things that I haven't asked you. Thinking about all the themes that come together in this book, all the things that you uncovered, both within your family and in the larger history of this disease, and thinking forward into its possibilities. What is there a big final statement you want to leave people with about these victims, or this bug, or this parasite, or this larger history that we all find ourselves in?
I would say I have three. So, something that I hope does stay with readers is that we could be doing prenatal screening for babies with Chagas disease. The CDC thinks there's anywhere from like 60 to about 300 babies born every year with this parasitic disease, and we completely miss them because we don't have guidelines at the state level nor at the federal level for prenatal screening for Chagas disease. And there's an economist who looked at what's the cost of doing prenatal screening of moms and babies and treatment versus waiting, decades later for that disease to show up, and then having to do all those interventions in terms of cardiac care. And she says it's 10 times cheaper to actually do that screening and that treatment early on. So I hope readers take that. I also talk in the book about the fact that most people with this disease in the US are actually in California, but we have had no significant public campaign about Chagas disease specifically in California. So I think that could happen. And then, of course, I hope that readers walk away and think, oh, healthcare access, that should be a human right. That should not be a perk that we get when we have a certain kind of job. We should not have to go through everything that we have to go through to get Obamacare every year. I say that as someone who had Obamacare for 2 years, very grateful for my Obamacare, but to go through all of that every year, just to be able to have something that should be a human right, having access to good care for our bodies. I really hope that people walk away with a sense of like, yeah, this should be for all of us, not just for a few.
Thank you so much for that, for all three of those. And thank you for this fantastic conversation. I'm
Thank
so
you
glad that you joined us tonight. It was just revelatory, and I'm so thrilled to talk to someone who is obsessed by scary diseases as I am. But also with all the also obsessed with all the larger contexts and connotations of neglected tropical diseases and their vast importance that we mostly miss here in the United States. So thank you for sharing that with us. Everyone, this is Daisy Hernández of Miami University in Ohio. Her book is The Kissing Bug, a true story of a family, an insect, and a nation's neglect of a deadly disease. It's out now in hardcover. It came out in June. Please go buy it. And please join us next month when we'll talk to Olivia Campbell about Women in White Coats, the book about the first women to be licensed to practice medicine in the United States. On behalf of Emory University Center for the Study of Human Health, and the Georgia Center for the Book, I'm Maryn McKenna. Thanks for joining us tonight. Thank you, Daisy.
Thank you, Maryn. I really appreciate it. Good night, everyone.
Good night.